Yes.
What ideas came up?
Let's see, more consistent attendance, consistent income.
Yes.
Being able to treat more people from a larger catchment area. And retirement options are extended.
Yeah.
Very nice.
Yeah.
Absolutely.
And then also the consultation piece. We like that idea, bringing in someone else. But then the question was, how is payment divided between two providers in one session?
Great suggestions and also great question. Here.
Well, I guess we just discussed some of the things you brought up about kids. I deal with a lot of adults. They love technology, so they do better with that. And also what you were saying about a kid has, soccer practice or field hockey, and the only time they come at 7 o'clock at night. I just had that situation last night, and I had to cancel her, knowing I had to be here, so I didn't get. So definitely benefits that way, and I just think some people might be more comfortable sitting in their own house. I like this Skype because I want to see their eyes, I want to see the interaction. Sometimes if they're in their own environment too, it's nice to kind of see them in their own environment. I had a little boy that broke his leg and he couldn't get out, so we Skyped, and he's ADD, and so it was interesting to see him, his mother in the background trying to get stuff.
Hey, where'd you go?
Right, so, yeah, there's a lot of benefits to it.
Great, thank you.
We talked about kind of individual situations that we're in now where it could be useful with somebody who's just gone off to college, or somebody who has a work problem, or weather or illness. A little bit about the retirement options, phone call, vacation.
Vacation, what is that?
Vacation.
Paid vacations, what?
What, really, a shocking idea. And then maybe getting paid for time we're already spending on a kind of phone call, or to be able to do that on a phone call or a Skype thing. So then you can actually see the person instead of just have the phone call for somebody that wants to see them.
That's a fantastic point. Fantastic point. Great. Anyone?
I'll talk. So we didn't follow instructions. We talked about problems.
All fine, right? We're all accepting.
So can you pick up on the nonverbals as well through a video feed through live? And is it legal? You have to keep track of where you are and where the client is. But on the positive side, someone that works for the Department of Defense or is just deployed, you wait for them to get services where otherwise there would not be any services available. And also emergencies. Emergencies was both like a hurricane. Is it legal for us to provide services to somebody in Florida, Texas? So there'd be a way for them to get services if they needed.
Great question. Make sure you keep some of those questions in your mind or at your table, write them down, because as we start going into logistics, we're going to talk specifically about HIPAA. We're going to talk about interstate practice. So I'll pause and we'll ask some questions about that for clarity. So make sure you don't forget those. Those are all excellent points. And the Department of Defense, the VA, they do have they're the unicorn of the counseling world, that they have magical powers that we aren't going to get unless we contract with them or we work for them. So there's an important, just being a provider of military insurance does not entitle you to being part of the unicorn club. So we'll talk a little bit about that. Great thoughts, great examples. So here's that history lesson I've been promising you. So from earliest recorded times through the 1950s, we have had this idea of remote care, this idea that people can't always be on site, or collaborating with care. So back in maybe some of the grimmer asylum days, people might be sent states away for care, and that's back in the letter writing days. So physicians would write letters to families asking for more information or giving patient updates. And that is a form of, so today we'd email, But back then it was, Pony Express. So we've had this idea that we have to collaborate over distance. Then we had the phone. So again, patients that are far away, doctors call families to update and inform about patient care.
It's also with the phone is the FaceTime too. People are familiar with that. You might want to mention that along with the Skype and stuff.
Absolutely, FaceTime with iPhones. So if you have an iPhone, that's a integrated video platform in there. Absolutely. So 1960s to 1980s, telemedicine was funded by grants and pilot projects. So we're seeing the money go to the universities. Academia was really big in saying, hey, this kind of might work. The idea was to build capacity, but it flopped. As soon as the grants ran out, there wasn't anything that continued. The cost was too great. There were logistics. It was in the 1980s. Anybody ever rent a VCR in the 1980s? Right? You had to go to like Blockbuster or something. You had to leave your credit card there because they were like $900. So if you didn't, you busted it or something. Right? I mean, there was no technology, not like we have today. So it didn't work. And there was a lack of reimbursement models. And I'm glad to hear you saying, so I have a business to run. Because we don't talk about that enough as counselors. Of course, we always think of our clients first. And we're always ethical in what we do. But we have to pay our bills and feed our families too. So that's something important. We're going to talk a lot about that today too. So the 1990s. Anybody have a bag phone in the 90s? Like that was the thing. You had a bag phone just in case you had car trouble on the Vermont roads where, by the way, we didn't have any cell towers. So it probably wouldn't work, but you felt better having that big bag phone. But we did see technology. Technology went from this big to handheld. We saw a huge boom in technology, and we started seeing other models. So our jails and our prison systems can't really safely transport those folks to the doc for a sinus infection. It doesn't work. They needed that kind of clinical specialty, so we're starting to see more telemedicine. It's starting to have a stronger research base, and there's starting to be some reimbursement models. The VA was one of those. They've done a ton of research. IHS is Indian Health Services, so another part of the government. They've done a lot as well in their rural areas. And the Department of Defense, they've done a lot as well. So they hadn't necessarily opened that up. As we'll continue to see, there are some limits there, but the research base grows. Feasibility, efficacy, what populations is it working on? So research really started research and technology really started to catch up. In the 2000s, we expanded more into academic settings, and we started seeing more age groups. So now it wasn't just in a psychiatric hospital or in a prison. Now we do this with kids. So we can try it with kids. Does it work? Well, yeah, it works. I mean, how many parents do you educate? Like, yes, you have to take the phone away from them or they will use it all the time. Kids and teens are like, yeah, that's what I do. So they love technology. Video conferencing became not just this pixelated, lagged, weird conversation, but it was like real time. Video conferencing, FaceTime, Skype became things in terminology people used every day. So we might call grandma, it didn't cost any money. And this was fantastic ways to bring people together, and in academic and research settings we're seeing it too. We also started to see large platform, large research studies that were saying, you know what? The efficacy rates are as high or higher in some patient populations as they are face-to-face. And initially, I have to be honest with you, I went, no it's not. But no it's not. You can tell any tale you want to with research. No it's not. But study after study after study started to show that efficacy actually is demonstrating that under the right conditions, patients are benefiting from this care. And they like it. They like it. Who wouldn't like having to, so I practice in Central Burlington provider. So I have clients whose parents work in Burlington come to my office at 2 or 3 o'clock in the afternoon, whole day off of work, whole day, have to take a half day. And for the single mom who is struggling, loves her state job, she's got to go through the union, she's got to get a time off, she's got to drive here. Right? So these are real ways patients and their families are benefiting. The access to care is not creating additional family stress. Program descriptions and feasibility. So we're starting to see two terminologies coming. Structured, a structured setting, you'll want to put that word in your notes, is a clinic-based setting. So that's if you go to the doctor and they're like, oh, the doctor's actually not in today, and they pull in the telemedicine cart, and you're like, what? And the doctor greets you on a telemedicine cart from home or another location. That's a structured setting. If you have a stroke right there in that patient room, all the staff are going to come in, they're going to call 911, and you're going to be taken care of. An unstructured setting is what's referred to as something else, so something without medical or support staff there. That's going to be home, patient's work, their car, their vacation house, wherever they might be. So we're going to look at some of those differences between benefits and risks of a structured setting and an unstructured setting.
Would the term structured apply to an individual in private practice?
So it could. So if you, for example, had a receptionist in your practice, so in our practice, it would be a structured setting because we have administrative staff in our office. So if that client came to see me at 10 o'clock in the morning and they went into my office and had an iPad and I saw them through a telemedicine platform from home, that would be a structured setting. If that patient had any kind of an emergency or anything like that, I have colleagues that could assist. I have a receptionist that could seek support.
If you didn't have office staff, if you're just there by yourself and you see them face to face, is that structured?
That would be unstructured because the patient would be, are you talking about an in-person?
In person.
So in person, that would be really different, and this wouldn't necessarily apply because you would be the structure.
But it would be categorized as structured?
It would be categorized as structured, yeah. Because if there's a client emergency, you're going to handle that emergency. You're the backup.
So if you're in a suite,
Yes.
would that be, with other practitioners, would that be considered structured?
Sure, could be.
Okay.
Absolutely. Yeah, absolutely. So what we want as practitioners is we want the ability to practice in an unstructured setting as allowable by law, because that allows us to be wherever we want. If I'm in my office and I have a 2 o'clock opening, that patient calls me and says, oh, I'm snowed in. I think I heard you say something about being snowed in. Oh, I'm snowed in, I can't get there, the roads are too bad. You go, great, let's telemedicine, I'll send you an invite, and we'll just do it that way. And that's a great way. So that is an unstructured session in its format, in its delivery, because there's not someone there with that patient, right? A clinical staff, right? With outcome measures, we talked about the face-to-face, and then just some of the economics of this kind of care. I don't have any, and in your folders, I don't have any research studies for you. If you are not familiar with Google Scholar, that is an incredible source of information. It certainly is not as complete as like EBSCOhost at a university library, but there are a lot of full-text research articles on there. You can save them, you can print them. It is a fantastic resource. Again, it's not going to be complete research database, but it is amazing what you can find. So you go to Google, type in Google Scholar, it'll take you to Google Scholar, and then you can do some research there. So you could research telemedicine anxiety or things like that if that's important to your practice. All right, so just a final thoughts as we kind of wrap this up, and then we're going to talk a little bit about models of care. So we are going to see, I really want one of your main takeaways to remember this is a changing area. This is a changing area, so as a provider, you must protect yourself by staying current. You must continue to check manuals and protocols from the insurance companies you're credentialed with. They change them. Some are fantastic about communicating. I think Blue Cross is amazing. Some are horrible at communicating. But because of your contract with them as a provider, you are required to know and to implement those changes. So there's liability there. So commit to checking those every couple of weeks. If you don't know where those are, your provider rep can tell you, whoever you're credentialed with. So this is still evolving. This idea of unsupervised settings is something that is now allowable in the new mental health bill, and we're going to talk about that next. The Vermont S50 bill removed, so in Vermont, we've actually been allowed to do telemedicine for some time, but there was what's called a location restriction. So that patient could come to your office. You'd have to have administrative staff. I don't think you can give your patient a key. That's a whole other HIPAA problem. They'd come to your office, and they would sit down in your office by themselves with a device, and then you could telemedicine from anywhere you wanted. Well, that doesn't make sense in mental health practice. Why would we do that? We wouldn't. So it's a barrier that we have that has prevented us from being able to bill for these services. So we have that location restriction lifted October 1st. So patients can be anywhere, and so can we. Okay? So we're going to talk a little bit more about that, but we are super excited about that. All right, so here is just a visual of those sort of benefits and some of the risks. So traditional is what we'll call structured. So that's where a patient comes to you, they come in your office, you guys sit down and have a session, versus online. We'll call it online just because we'll assume that it's whoever's paying the bill, whether it's synchronous or asynchronous, we'll just call it online, okay? So supervised setting, you're there. You're the plan B if that patient has a crisis of any kind. In the online model, it's the patient home, and they're generally not clinically supervised unless the patient's parent is a doctor or a therapist or something like that. So they're going to have parents there, probably if they're a patient, but they might be home alone. They might also be at work if that's something that they do. In the traditional setting, doctors can do a little bit more. They can monitor a medically ill or cognitively ill patient. We need to be a little narrower in our selection criteria, and that's going to go back to that competence with you as you get competent with technology and then figure out your scope of practice and what you're comfortable with in this. A classic example might be if you treat patients with personality disorders. So how clinically severe is that patient's presentation? Are they a good fit for telemedicine, or do they really need that face-to-face? So some examples of that. The environment in the office is more set up and controlled. Online, they need to adapt. The patient is really responsible for that technology. And then for emergencies, there's on-site staff, and online, you're going to use protocols, and you're going to have a lot of trust in your patient that they're going to be collaborative in those. All right, so let's talk about some models of care that we're seeing, and we're going to demonstrate some technology a little bit later today, right around lunch or a little after lunch. So some of the ways that this can be done, right, is that we can have more of the private practice model. Okay, so this is basic fee for service. A client, you hold a telemedicine session. The client, you are reimbursed by the insurance carrier for that. So this is basically what most of us are doing now, with some, with the exception of private pay. We have the consultation model. Which is more of a one and done. That might be that you consult as a substance abuse counselor to a particularly difficult clinician, a particularly difficult client, or got a really unique presentation and you need someone else to help to weigh in on that. We also have, because telemedicine is not new across the country, we have some very large national cloud-based clinics that have popped up. Anybody have Blue Cross Blue Shield as your personal health insurance? Okay. Do you recall getting the letter about American Well as a subscriber? So American Well is a large national cloud-based clinic, meaning that they have contracted physicians that Blue Cross Blue Shield has contracted with, and Blue Cross patients can log on to American Well, put their subscriber ID in, pay their copay or their payment if necessary, and go into a queue to see a doc. So it's 1 o'clock in the morning and your kid's got a fever and they're coughing really yucky and you're a little concerned and you don't want to put them in the car and go to the ER and sit there for 4 hours. You are a Blue Cross subscriber, so you log on to American Well. Their wait time, they have very aggressive goals for wait time in minutes or less than minutes. And they have doctors on staff, and Dr. Smith says, hey, how you guys doing? I understand you've had some, so-and-so's coughing. And they do that session, and they can prescribe, just like that. So social workers. Social workers can be credentials with American Well right now, along with PhD level psychologists. Though the rest of us as mid-level providers, they do not have credentialing with right now. My guess is part of that has to do with national level licensure standards and acceptability of those, and many of other licensure types, there's not necessarily national standards for that. So you would credential with the company, and they would pay you a rate for each client that you saw with that. You're not your own boss. I mean, you can accept or decline referrals, but you would have more structured time, and you could commit to blocks of time. The final one would be an employee-based model where you would become an employee of a company, and then that would be your job, is to do that. Not hearing a lot of that in Vermont. This is what I'm seeing right now. This is a big pull for physicians right now to sign on as contractors and do some specialized work. And then also for social workers, that's there. We will show you some other technology for mid-level providers. There are a lot of other options for contracting with different service providers. We'll demonstrate some of those for you today, and then you can seek those out if you're interested. All right, we talked about the inexpensive technology. We have we talked about one of those models as a web-based and outsourcing some of that. Let's see what I want to say about that. Thank you, Amanda. So again, remember this is changing. You must commit to staying literate on your provider panels. They can be different, so you need to know which one expects what. We've got good efficacy and a research base, so we know that ethically we can step in this direction. And all these models of care have some drawbacks and some benefits, but also telemedicine versus face-to-face, right? We have to have good client choice. So open up your packet. We provided you with the Senate S50 bill. I'm going to grab one over here. So this is the bill as it passed in its final revision. This is the marching orders, if you will, for the insurance companies that provide coverage in Vermont. So if you go to the bottom of that first page, underlined it says, a health insurance plan shall not impose limitations on the number of telemedicine consults a covered person may receive that exceed limitations otherwise placed on in-person service. The other thing I want you to flip over, so I'm going to hit some highlights and then we'll answer questions. Page 2, which is on the back of that. And if you look down almost to the bottom of the page, letter H, number 1, distance site means the location of the healthcare provider delivering service through telemedicine at the time of the service. Okay. Flip over one more page. So we have, when we look at 18 BSA 9402, we have what a healthcare provider means. So this is now defining who can provide telemental health. And you'll notice we've got physician, naturopath, advanced practice nurses, physician assistant, psychologist, social worker, alcohol and drug abuse counselor, clinical mental health counselor, marriage and family therapist, psychoanalyst, and then there are some others. So this is what gives you and your licensure type the ability to practice telemedicine under these specifications, all right? All right, so, excuse me, flip another page for me. And then we're going to go, excuse me, we're going to go down to number 5. Originating site means the location of the patient, whether or not accompanied by a healthcare provider. So there's our permission for unstructured settings. At the time of services are provided by a healthcare provider through telemedicine, including a healthcare provider's office. So they can come and sit in your office. You can give them a key. I'm just kidding.